Let me share my slide with you. Can all of you see my slides and hear me?
Yes, we can, Yeoh.
All right, okay, good. So this is my disclosure, and here's my outline of presentation. I'll start with some introduction, and we'll talk about the natural history of chronic kidney disease progression to help us to understand the pathological basis and then how to treat it, and what are the evidence available, and what are the clinical guidelines standing so far. So chronic kidney disease plays a heavy healthcare burden to our country's healthcare resources, and also significantly impact the quality of life of the patients. So from the latest statistics available from Malaysia, based on the report published in 2018, because usually the statistic collection will be a few years lag behind the actual statistics. So in 2006, we only have 15,000 patients receiving dialysis in Malaysia, but in 2015, roughly about 10 years time, it has doubled, more than twofold, okay, to 37,000. And new dialysis patients more than 55 years old consists of 51% in 2006, whereas in 2015, it consists of 58%. And diabetes mellitus constitute majority of the patients who is having end-stage renal disease, which is 61%. So this chart shows you the dialysis treatment rate according to age group. As you can see from the chart, those with age group, higher age group, having constitute the majority of the patient with on dialysis. And the major diseases that causing renal failure, as mentioned just now, are diabetes mellitus. And there's quite a large proportion of patients have unidentifiable cause. And the rest are toxic nephropathy, hypertension, and other causes. And glomerulonephritis and SLE also constitute a small portion. And so same for polycystic kidney disease and obstructive uropathy. So these are the main causes of CKD that leads to dialysis among Malaysian population. So now we will be talking about the natural history. Naturally, the GFR of a patient, as we know, progress with age, and normally men progress faster as compared to women. So this table shows you Just one moment. I think there's some problem with my screen and I cannot hide. So this table shows decline in kidney function in various populations, which covers the healthy population and patients population with comorbidities, as well as older adults with or without diabetes. And as you can see, for the healthy population, the healthy kidney donors annual kidney decline, GFR decline is about 0.4 mil per minute per year. And the highest level for a healthy population is up to 1.21. This is from healthy adults from Norway. As for the patients with comorbidities, surprisingly, the range for healthy adults from these various studies are between 0.36 to 1.21 mil per minute per 1.73 meters square per year for the decline in kidney function. Whereas for those with comorbidities, male with hypertension surprisingly only decline with a rate of 0.92 mil per minute per year. And even surprising is that adults with impaired renal function declines at such a low rate. So the explanation is that this may be due to a phenomenon known as regression of mean. Okay, so another population being studied is older adults. Okay, as you can see here, those with diabetes have more drastic decline in their renal function, which is 2.7 mil, and usually male decline faster as compared to female, which is 2.1. So so this makes the range of the GFR decline for healthy population ranging from 0.36 to 1.21, and those with comorbidities ranging from 0.05 to actually 2.7 for those with diabetes. So it's quite a broad range. Sorry. So this chart shows you the decline in kidney function in CKD population. So as you can see from the various studies here, is for the population being studied is followed for relatively short duration, maximum up to 4 years only. So as for this study from right, who only focus on African American with hypertension and GFR between 20 to 65, has been followed up for a median of 40 years, a mean of 4 years, and the decline in GFR is ranging from 1.95 to 2.21. So if we combine all these different studies, the range is also quite broad, which is 0.35 to 4.9. So one thing we should remember is that kidney function does not follow the graph of a decline as for the normal population. There's a variety in trajectories of change in renal function over time among those CKD patients. This is a study carried out from African American individuals aged 18 to 70 years and follow up for 3 to 12 years. And the probability of getting a linear kind of decline in kidney function is almost zero. And there are about half, you have a curve of like somewhat sinusoidal, and there's about 40% of patients from this study, and probability of about one among those study population have a unpredictable cause. So this reflects that chronic kidney disease does not progress in a steady course. Actually, the patient may have a insult to the kidney intermittently with AKI, or exposed to certain nephrotoxic drugs or other factors which may temporarily affect the kidney function. And some of them may recover partially and some of them may recover fully, but they won't follow a very nice curve. So and this is another example to show that the progress of the decline in kidney function in different groups. So in group 1, the patient has persistently low level of eGFR, which is about 63%. As for group 2, progressive loss of eGFR constitute about 25% of the population studied. And for group 3, they have accelerated loss of eGFR, which is only 9%. And catastrophic loss of eGFR, you see the curve drop drastically, constitute about 3%. So in conclusion, CKD progressed at different states of different rates of decline depending on multiple factors. So before we talk about slowing progression of CKD, we need to know the definition of decline in kidney CKD progression, which is developed by the professional society. So KDIGO 2012 clinical practice guideline for the evaluation and management of CKD defines CKD progression as fulfill at least one of the following. Number one is decline in GFR category, says from category 1 to category 2, and there must be a certain drop in eGFR is defined as a drop in GFR category accompanied by at least 20%, 35% drop in eGFR from baseline. So what does it mean? Okay, for example, if you have a patient who has a eGFR, let's say 62 mil per minute, that came to you 3 months ago, and then this month when the patient came to you, the eGFR is only 58. So there's a drop of 4 units from category 2 to category 3A. Does that mean that this patient have CKD progression? the answer is no, because the job is so small and the definition is arbitrarily defined according to a certain level. And this is not significant and may just represent physiological variation. So therefore, at least 25% drop in EGFR from baseline is a must to say that there's a certain drop in EGFR. And another definition is rapid progression. So it's defined as a sustained decline in EGFR of more than 5 mil per minute per 1.73 meters square per year. If you remember the slides I showed you just now, the decline in EGFR according to different population, I think the highest is less than, the range is about 4.9%. Sorry, 4.9 mil. So probably this is being used as a cutoff point. And also, of course, they are based, some of the recommendation is based on studies carried out previously and using the study criteria. So the more assessment, the more blood taking being done, number of serum creatinine measurements being done, and the longer the duration of follow-up. So I mean, the confidence of determining progression will be more accurate. So in general, we need at least 3 measurements to estimate a slope. Okay. So this figure shows you the mechanism underlying the progression from early stage to advanced chronic kidney disease. When chronic kidney disease occur, usually there's about 50% loss of functioning nephron. So there will be homeostasis adaptation, such as hemodynamic changes and glomerular hypertension, to compensate for the function of a dying nephron. So the surviving nephron has to work harder. So the single nephron hyperfiltration will occur. And at the same time, there will be activation of the RAS, and proteinuria will ensue, and there may be systemic hypertension due to changes in renal blood flow as a result of the changes in the glomerular circulation. So and as you can see here, hyperlipidemia and systemic hypertension does contribute to the progression of chronic kidney disease. Somehow, hyperlipidemia, by treating hyperlipidemia, I mean, so far, has no evidence that slow the progression of kidney disease, chronic kidney disease. So all this process leads to upregulation of the cytokines, and then it involves mesangial cells and podocytes, which is important in causing this proteinuria, and endothelial cells. Various cells are involved in the kidney, and eventually the end result is glomerulosclerosis and interstitial fibrosis. So okay, this diagram just shows you that the effect of proteinuria on the proximal tubular cell. Okay, so all the disease process, such as glomerular disease, interstitial diseases, or patient after undergoing transplant are considered to have chronic kidney disease. So they will undergo a final common pathway as described above, with mechanism above, to progress gradually to end-stage kidney disease, and they are also in increased risk for cardiovascular death. So hypertension and activation of the renin-angiotensin system obviously accelerate the process, and also other factors such as smoking, obesity, and proteinuria. And at the same time, intercurrent illness that causing acute injury itself to the kidney also contribute to acute kidney injury on chronic kidney disease. And sometimes the kidney function may partially recover, sometimes they just get further worsen and eventually progress to end-stage kidney disease. And there are implications of this nephron number to the function of the kidney, and these are partially genetically determined, and of course also depends on other factors such as maternal factors, and also whether the baby is born premature. So when baby who are born with low birth weight or premature, usually will have low nephron number because the kidney size is proportionate to the body surface area, and they will have a large glomeruli and altered renal sodium handling, and as a result, it leads to hyperfiltration, salt sensitivity, and reduced renal functional reserve, reduced GFR, proteinuria, hypertension, and the common end result is glomerulosclerosis and eventually CKD. So now we go back to the main theme of today. So how to slow the progression of CKD? The strategy is number one, treat potentially reversible causes. Okay, hypertension, diabetes, glomerulonephritis, and obstructive uropathy. Once it's being corrected, it may halt the progress. And second, prevent further insult to the kidneys. We should avoid nephrotoxic agents such as aminoglycoside, okay, NSAID, right? And minimize avoidable episodes of AKI, unless it's, unavoidable. For example, use of contrast agents for CT scan. And number three is we should optimize control of modifiable risk factors. This include BP control of proteinuria by using ACEI and ARB, and glycemic control has been shown to slow the progression of CKD, including smoking cessation, which has robust evidence. And weight reduction for obesity has quite a lot of studies which shows positive results. And other beneficial therapies, the SGLT2 inhibitors, which is even beneficial among non-diabetic patients with CKD and proteinuria. So the CPG developed by this MOH on the management of CKD, which is published in 2018, are generally in line with the CPG developed by the National Kidney Foundation, which the KDIGO guideline, which is published in 2012. But somehow, I think this KDIGO guideline for CKD management is a document which has been published about 1 decade ago, which is 2012, and so far still has not yet updated. And over the past 10 years, there are lots of studies being published, and I think it's time for updating. So I think I just take this opportunity to tell you some recent updates, which is not in line with the recommendation by the KDIGO 2012 guideline. So initially, based on this sprint study, the Malaysian guideline recommends that there's a different approach in BP target for patients with diabetic kidney disease with proteinuria more than 1 gram per day or less than 1 gram per day. Those with heavy proteinuria should be have a more aggressive blood pressure control. However, subsequent analysis by the evidence review team of the KDIGO team has changed the recommendation. So let's see what are the evidence now. So the blood pressure management in patients with CKD with or without diabetes not receiving dialysis. Okay, this recommendation does not apply to patients on dialysis. So KDIGO last year published update a clinical practice guideline for the management of BP, blood pressure in the CKD, and they suggest there's difference between suggest and recommends. The wording they use in their guideline. Recommends means for most patients, they were advised to implement this strategy, whereas for suggest, it means when the circumstances permissible or feasible, or after like discussing with patients, and they have a full understanding and agree with the decision, and we may give it a try. So the target this systolic BP is less than 120, and it no longer differentiate between the target for high proteinuria or low proteinuria. And here I highlighted using standardized office measurement. Okay, actually there's a standard, there's a definition for this term. So it's recommended to use standardized office measurement because we don't want like white coat hypertension that leads to falsely high blood pressure, and then we are over treating patients, and by lowering the blood pressure too much, actually it's not good for this cardiovascular aspect. Okay, so they also suggest that in the guideline, okay, the sodium intake should be less than 2 grams per day, or less than 5 grams of sodium chloride. Sodium chloride and sodium is different, because the content of sodium, we are talking about content of sodium. If you are using sodium bromide, the content of sodium is less than sodium chloride in 5 grams. So yeah, and then but Of course, there's exception. For example, in kidney in patient with autosomal dominant polycystic kidney disease, we are aiming for lower blood pressure control. This is based on New England Journal study in 2015. So if you the benefits is greater with systolic BP of 95 to 110. Okay, so this is a standard BP measurement which you can access online from Google, and then okay, I think KDIGO 2012 BP guideline recommend more aggressive BP lowering for patients with albuminuria than for those without albuminuria, as I said just now, and subsequently the 2021 BP guideline evidence review team found no effect modification according to the presence of proteinuria, so they changed the recommendation. This is a flow chart to show the BP control for patients with CKD. Lifestyle modification, salt intake less than 2 grams per day, physical activity at least 150 minutes per week of moderate intensity. So target BP should less than 120. So these are just studies to show you that strict blood pressure control does not improve the kidney outcome or slow progression of the kidney disease. Okay, this is being asked in your MCQ questions. And okay, this AASK trial also does not show any statistical significance in terms of more tighter sugar blood pressure control on the progression of kidney disease. So you see the p-value here. Okay, it's not significant, right? And there's a meta-analysis showing that when you reach a blood pressure of 110 to 119, the effect of urinary protein is no longer important. And if you go lower, actually, it's even it has a detrimental to the patient. So I think I'm a bit over time. So I'll end this very quickly. Okay, this is just to show you that tight sugar blood control does not alter progression, and MDRD trial shows that there's difference, but actually it is being influenced by the modifier is because of presence of proteinuria, and so the interpretation is incorrect. So the Sprint research group also found that this is based on subgroup analysis, and subgroup analysis is debatable, controversial, because it's very difficult to derive a conclusion based on subgroup analysis. So as for glycemic control, the latest guideline for 2022 for diabetes management in CKD is ranging from 6.5 to 8.0. So it depends on several factors. Okay, we have to take into account life expectancy, comorbidities, and hypoglycemia awareness. All those things. You can read about it. So these are the evidence provided. Okay, and smoking cessation has robust evidence and has dose-response relationship. Okay, and so same for the BP control. SGLT2 inhibitor, is recommended to treat patients with type 2 DM who has CKD and EGFR more than 20 ml per minute. So we can initiate because it's associated with better prognosis for the kidney, slowing progression. So up to date, actually recommended for non-diabetic kidney disease with proteinuria. And so these are the evidence that published in New England Journal of Medicine. So those therapy of controversial benefits include uric acid reduction, protein restriction, bicarbonate supplement, and Mediterranean diet, statin, pentoxifylline, vitamin D analogs. I won't go through one by one. I think the evidence will be show it to you. You can have read by yourself. So this recent study published in 2020 about allopurinol by New England Journal of Medicine, which shows no benefits. And protein restriction has been recommended by 2012 guideline, but actually the evidence is very weak and controversial. So these are the evidence. And bicarbonate supplement also, yeah, very weak evidence. So I think Mediterranean diet also weak evidence. So I think that's conclude my presentation. Thank you.
Thank you, Yeoh, Dr. Yeoh, for the detailed lecture on chronic kidney disease. Because of time constraint, we probably can take only one question. I have one question in the chat box from the same person, but I'm not sure whether it is of two different patients. The first question is that a patient with baseline EGFR of 65 was started on ACE inhibitor, ARB, SGLT2 inhibitor. Was it a combination of all three, or is it either one? I'm not very sure, but after which the EGFR dropped to 49. So the decline was about 24.6%. And then the repeated EGFR after 3 months was 49. So the question from the participant is that should we manage this patient as CKD stage 3A?
This is a good question. We know that when the initial stage of initiating SGLT2 inhibitor, there will be a drop in EGFR. So what we need to do is to monitor it, and over time it will gradually pick up. Same for starting ARB or ACE inhibitor. So I think we need a serial reading of the serum creatinine in order to estimate, in order to determine progression, or instead of relying on a single reading. So that's the core message that I wish to convey. Yeah.
Yeah, there are multiple questions, but I think we are limited by the time. I think maybe Dr. Yeoh can answer the questions personally in the chat box later on to address the concerns.
Yeah,
so I think we should move on to the subsequent lecture, which is by me.
Okay.